Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm Gregory Phillips with Duke Communications. We've been living with COVID-19 for 2 years now, and it doesn't seem to be going anywhere. We have 3 Duke experts with us this morning to discuss what it would mean and what it would take for COVID-19 to become endemic and the extent to which that transition could already be underway. Joining us today is Jonathan Quick. He is an adjunct professor at the Duke Global Health Institute and author of the End of Epidemics, the Looming Threat to Humanity and How to Stop It. Also with us is Lavanya Vasudevan. She is an assistant professor in the Department of Family Medicine at Duke and the Duke Global Health Institute. And we have Christopher Woods. He is a professor of medicine, pathology and global health and chief of the infectious diseases division at the Durham VA Medical Center. Good morning, panelists, and we will jump in and get started. Professor Quick, we'll start with you. What would it mean for COVID-19 to become endemic, and why do you think it would be good for that to happen as quickly as possible?
Well, thank you, Gregory, and welcome to everybody. Good morning, good afternoon, good evening. I think none of us, even those of us who wrote about this, I think could have imagined that we would now be going into the 3rd year of the first global and really devastating pandemic of the 21st century. Which this started as all pandemics as a local disease outbreak. It quickly turned into an epidemic of larger scale, and then a global pandemic occurring worldwide, crossing boundaries and affecting large numbers of people. The last 2 years have been stunning as we've seen this progression of variants. Alpha, a little over a year ago, Delta, then during the middle of the year, and now Omicron, much more contagious, but mercifully less severe in the illness. The good news is that increasing population immunity from vaccines and natural infection are protecting more and more people around the globe. And new therapeutics are opening windows for treatment. But as Omicron peaks here and in the US and starts retreating in some states and around the globe, we're all wondering where from here. So from an epidemiologic point of view, if you ask the question, well, what happens with a pandemic? First option, or one option, first eradication, stopping all transmissions through surveillance and containment. We've been able to do that only once with smallpox, and highly unlikely with COVID. Second possibility is elimination, reducing the case transmission to some identified level, lower level, and with occasional outbreaks. That's happened. We were on the verge of elimination with the measles, which killed millions of children in the last century, and we're actually on the verge in U.S. We're on the verge in the U.S. and Europe around the year 2000, and then vaccine levels started decreasing, and we've sprung back with outbreaks through Europe and elsewhere. Polio is another example where we're headed toward elimination. This has been possible, and elimination is possible only with highly effective vaccines that provide lasting immunity, large-scale vaccination programs in every country, intensified global disease monitoring, and rapid, vigorous response to local outbreaks. Third option is for pandemic, is the next step, is to become an endemic disease. Plateau at a relatively constant level that's manageable, that lets society function. And AIDS was the first new human pandemic in modern times. It took 20 years, but that was eventually turned from a pandemic into an endemic disease due in very large scale to treatment. Vaccine we're still struggling with there. Zika, a pathogen, mosquito-borne pathogen that slept quietly for 70 years and then exploded across the world in 2015. Primarily to Brazil. That's now settled down to an endemic. So what about SARS-CoV-2? we have the tools to stop COVID-19 as a global pandemic. We need to be really clear. And I think, as we've all seen, the tools that have been developed are incredible. What this new normal looks like and how quickly we get there is going to depend basically on two things, which we'll talk about this morning. One is what the virus does, and so far it's been predictably unpredictable, and what humans do, what government leaders do, what public health officials do, what we continue to do in the scientific and development community, and what the public does. We're already on the path with the tools we have, and at this point, with the way the Omicron variant has managed to chase out the far more deadly Delta. But we need to be aggressively persistent and make sure that we keep on this trajectory. So the other question was, why move quickly? Moving quickly, we need to move quickly for three reasons. First, obviously, human lives. Huge share of the global population is still vulnerable. We're losing 60,000 people a month in the US, and globally, 4 times that much. We're adding nearly 6 million reported. We're at 6 million reported deaths, but it's probably 10 to 20 million when we look at the recent data on that. So human lives is a reason to move quickly. The second is the social and economic health. Trillions in recovery at jeopardy, disruptions in the next generation, all the things we've seen with the really stunning results of closures of it all. The third and most important, we got to understand this one, is the potential for new variants. The movement from the original strain to Alpha, to Delta, to Omicron basically was predictable. The virus's sole purpose in life is to go forth and multiply. And this was a continuing game of king of the mountain. And Omicron chased Delta away because it was more contagious. As Darwin said, survival of the fittest, not necessarily the strongest. And in this, with viruses, with pandemic viruses, the fittest is the one that's most contagious. The move to deadliness is a bit more random. It's a genetic roulette. We were lucky with Omicron, but as long as we have the extent of viral activity around that we have, the more contagious is going to rule. But what would be really unfortunate if, after all of the current viral activity that's going on with Omicron, we had a variant, and there's no reason why we couldn't, that combines both the contagiousness of Omicron and the deadliness of Delta. So endemic is getting us back to a manageable level. We'll talk more about that. But we've got to move quickly because of the ongoing threat of variants that escape our immunity, and at the same time become more deadly.
Absolutely, thank you.
And back to you.
Yes, thank you very much, Professor Quick, for setting us up there. Professor Woods, I'd like to move on to you. Where do you think we are in this transition to endemic disease?
Yeah, really important question. I do feel like Dr. Quick, this is a bit of deja vu, and I feel like we've had similar conversations last year, the year before, and I'm just hoping we're not going to have the same one a year from now. I do feel that we are moving into a transition phase in the pandemic, and I do think Omicron represents a major move towards endemicity. That's my optimistic outlook at the moment. Virologically, the strain is clearly more transmissible, as Dr. Quick alluded to, due to a number of factors, viral and human immunological. It doesn't appear to result in severe disease as often as its earlier iterations. Let's be clear, that doesn't mean that it will not cause severe disease, particularly in the unvaccinated or vulnerable populations. Notably, we do seem to be plateauing now in most locations in the United States, as Similar data are being reported to me by my colleagues around the globe as well. Each region does have its own unique aspects, however, and needs to be monitored. Again, I'm personally of the belief, which is shared by many of my colleagues, that this rapid surge that's responsible. We're seeing 750,000 to 1 million cases here in the United States each day, will augment population immunity to help us be more immunologically resilient, at least in the short term. Though we will certainly bear the pain of this surge to some degree with hospitalizations and deaths, despite the lower case fatality rates. I believe the result will be fewer infections over the spring and into the summer, at least from Omicron. We may well see that there could be the emergence of a new strain that will potentially outcompete Omicron for dominance, and it could be a more severe disease, just as Dr. Quick already alluded to. Regardless, I do feel that, like other coronaviruses that we're familiar with, that there will be a transition to seasonal peaks, most likely in the winter with other respiratory viruses, including influenza. As with influenza, there will almost assuredly need to be an annual booster, if not more frequent. Those vaccines may well need to be periodically updated to, like flu, to represent what is being transmitted at the moment. Now, I would want to mention that in addition to the scientific or medical aspects of the endemic transition, that there are also socio-behavioral and political components. And it's fairly clear that we are adapting to the rhythm of these surges, titrating our risk tolerance as epidemiological data suggests that we should. And I suspect we're all doing this to some degree, canceling trips, fewer meals out, greater adherence to mask wearing and our social distancing, et cetera. That takes place during these surges, and we hear that most of us are changing our lives accordingly. Now, there are metrics such as mobility indices or economic normalcy indices that reflect this adaptation, and we see them taking place now as data become available in response to the current Omicron strain. This highlights the need for precision public health or ongoing surveillance to include strain sequencing to help monitor this pathogen as well as others. And that's where the political will ultimately is going to be needed and has traditionally waned. So that would be my opening statement as we continue the discussion this morning.
Absolutely. Thank you, Professor Woods. We've already got lots to dig into there. Professor Vasudevan, I'd like to move over to you. We know Professor Quick was saying one of the elements of this is having a highly effective vaccine, which we have, and you need a very successful vaccination campaign. Can you talk a little bit about the role that vaccinations play in getting us to an endemic phase with this disease?
Yeah, Greg, there is no doubt in my mind that vaccines will continue to play a central role in our fight against COVID-19 as we transition towards a more endemic phase. And that's because the vaccines that we have, particularly here in the US, have excellent safety profiles and effectiveness to prevent severe COVID infections and death. It is actually frightening to think how much bigger the toll of COVID-19 would have been without these vaccines. So while I'm cautiously optimistic, I do think we should stay vigilant and keep our guard up, especially since we don't know how the virus will continue to evolve. I think this added immunity from people recovering from Omicron infections represents an opportunity for us. And that's an opportunity to continue using the safe and effective vaccines that we have to suppress future waves of COVID-19 and progress towards endemicity. We know that most people who are in ICUs today are unvaccinated, and unvaccinated individuals remain at some of the greatest risks for COVID infections and severe COVID infections. There is much work needed to increase vaccine equity here in the US and also to expand global access to vaccines. There are many countries in the African region today where less than 10% of the population is fully vaccinated. And so we need to continue to make progress in increasing vaccine demand, access, and equity if we are to reduce the likelihood of more deadly and transmissible variants. I think moving forward, once we are in the endemic phase, our goals will remain the same. Our goals would be to preserve life, and second, to reduce the societal and economic impact of COVID-19. And again, all the data that we have right now continue to point to vaccines as our most powerful and effective tools to help reach those goals.
Absolutely, Professor Vasudevan. Thank you very much. And thank you to all of our panelists for those opening questions. We're now going to open it up to questions from people on the call. Thanks to everyone who submitted questions in advance. We'll start with those. You can also post questions via the Q&A window at any time. If you would like to ask your question in person, raise your hand in Zoom and we will unmute you when your turn comes around. If you're calling in by phone, you can raise your hand by pressing *9. Professor Quick, I'd like to come back to you. One of the ways you just characterized an endemic phase is when cases reach a plateau that kind of lets society function. And I'm wondering if you can talk in a kind of real world examples kind of way, in that based on what we know about the pandemic in the last 2 years, what an endemic phase of this disease would look like. Professor Woods mentioned, regular vaccines like a flu shot. Is this something where we could see virtually no cases for a period of time during the year and then an explosion of cases, say, at winter? What can we say right now about what an endemic phase of COVID could look like in the real world?
Yeah, a couple of things that I'm sure Chris Woods will want to come in on this. I think it's pretty clear that human behavior is seasonal. It's still unclear whether COVID itself is going to turn into something seasonal. So I think that's something to keep our eyes on. But I think the key thing is a level of immunity where basically we can go about our daily lives, and a little bit like we now have warning systems with weather and all, that there will be. I mean, the history of this virus so far is that it's gone in waves in different places around. It's gone north, south, winter and summer, and so I think number one, getting all of these measures in place, and we can talk more about some of the issues of what are some of the key tools. But I think if we think back to where we were in last June, where the virus was still around, we were cautious about where we went, but we were able to live more normally, and I think that's the level that we're aiming for. But it is going to take a strong data backbone, the diagnostics, vaccines, therapeutics, and this public health early warning system that's really responsive. Because what we can't do is drop back into complacency and say, oh, the war is won. This has been too mercurial a virus for that to happen.
Sure, absolutely. Thank you. Professor Woods, I wonder if you could add to that and talk a little bit about what we know about how COVID-19 might manifest in an endemic phase.
I am very pleased that Dr. Quick and I are similarly emphasizing the need for a ongoing investment in our public health infrastructure, in surveillance, and in the technologies which we've invested so much in the early phase of the pandemic, and making sure that those technologies are available in an equitable fashion. I think that's kind of the key elements, and we don't want to lose vigilance as we continue to, what I'll say, progress into an endemic phase, because as noted, what we're liable to see is intermittent surges of infection that may reflect either waning immunity, and to Dr. Vasudevan's point earlier, we need to be especially vigilant now about making sure that vaccination is available to all of our populations in the US and outside of the United States as well. And that's important because that retained immunity lessens the likelihood of new strains pushing those surges. If they are, if it's Omicron that kind of comes back as immunity wanes, we're much more likely to be able to handle that as a population, as opposed to if we have a newer variant that potentially has greater severity associated with it. I do want to respond to one of the questions in the chat at the same time, which I think is part of what the future of the pandemic looks like, and that is with masking. And I think that's one of the more intriguing questions about what will likely happen in the future. And I know a number of us have postulated about this over the years, or over the last couple of years, what it will look like in the endemic phase. Are we always going to be wearing masks? And count me among those that doesn't enjoy wearing masks, but it feels it is my duty to protect others, both inside the hospital and outside the hospital. The hospital, the healthcare setting, I think will have masks most likely of the N95 or K95 variety for the foreseeable future. I think as we get on airplanes, those are, and other, mass transit mechanisms, we will continue to wear masks in greater number than we've historically, for sure. I do think that will wax and wane with the epidemic information our surveillance system feeds us. That's going to change our social behavior, and we will probably be more titrate up to a more adherent approach to masking, and as well as the other aspects of pandemic prevention.
Oh, sorry, I muted myself. Thank you, Professor Woods. Professor Vasudevan, moving on to you again. We know that vaccination is going to continue to play an important role moving forward as we move into an endemic phase. Obviously, the vaccination campaigns have been very successful, but there's also remained a lot of hesitancy out there. What do you think that we have learned from how vaccination campaigns have unrolled in the last year that we can learn moving forward to maybe address some of the hesitancy issues that we've seen over the past year? Is there anything we have learned that could improve vaccination campaigns, do you think?
Yeah, so our vaccination campaign and efforts certainly evolved over the course of 2021. So at the beginning of the year, our focus was more on messaging around the risks of COVID, the safety and efficacy of the vaccines that were available, and then increasing access and clarifying eligibility, right? As the year rolled on and vaccines became more available, the messaging focused more heavily around the safety of the vaccines, and then towards incentives, right? So we saw a lot of programs where states were giving educational lotteries or other monetary prizes to incentivize vaccinations. And then we saw the move towards mandates. And this basically speaks to the fact that there is really no one-size-fits-all strategy when it comes to vaccination promotion. And moving forward, we would need to continue to use a combination of these strategies. And that's because everybody has different priorities and motivations when it comes to vaccinations. Definitely in my own research, I've found a variety of decision-making styles when it comes to vaccinations. There are individuals who have high perceived risk of disease who usually don't need any kind of interventions. They're ready to be vaccinated. And their primary needs are around getting access to the vaccine or having a more convenient way to get vaccinated. Then we have individuals who are either indifferent to vaccinations or have other competing priorities that prevent them from getting vaccinated. And definitely for those populations, incentives and mandates are effective. And then you get towards a group, as you mentioned, Greg, who are very hesitant to get vaccinated. And that's where we need to start engaging in one-on-one conversations around their concerns. And I think the best opportunities to have those one-on-one conversations are in the doctor's office. So moving forward, we need to increase or put in place mechanisms to train providers and incentivize them to engage in those conversations. Again, there is no magic word or phrase that we have identified in the past year that providers can use. Rather, it's a process. a conversation or multiple conversations where providers use empathy and active listening and respond to individual concerns. So we've seen an evolution, we have learned a lot. Moving forward, we need to use a combination of the strategies that we have already been seeing.
Sure, absolutely. Thank you. And if only there were funding for linguists to figure out what the magic word was, because if we could find the magic word, that would solve an awful lot of problems. Okay, thank you everyone for all the questions tumbling in. We're going to get through as many of them as we can. Professor Quick, I'd like to come back to you. You mentioned how a kind of early warning system would be an essential part of kind of managing this in an endemic phase. And we've had a few questions that come in around that. So can you talk a little bit more about the fact that, for example, given that it takes a few days for symptoms to show and asymptomatic people can transmit the virus, what do we need to do to develop an early warning system? What could that look like and what would the components be?
Okay, Gregory, I'm coming on. Are you able to hear me and see me now?
Yes, absolutely. Yep, okay. we can hear you and see you.
As usual, technology is not always with us. So, yeah. So the early warning system. I mean, and this also a little bit of a response to one of the questions about when are we going to call it endemic. I mean, I think the reality is that we still don't have a clear sense of the durability of the vaccines we have. So I think if people are hoping that once Omicron, as it appears to be doing, comes back to a steady state, comes back to, drops off and comes down back to the relatively low level we were, say 6 months ago, there's going to be a tendency to say, okay, let's back off. But given our evolving knowledge about the durability of the vaccines we have, given our need to really make a much more concerted effort toward new vaccines that cover a wider range of coronaviruses, we need to stay on the alert. And it would be 6 to 12 months at a sort of a reasonable stage before I would be comfortable saying that we may be out of the woods. So the early warning system, I think what we've seen is a development of first of all, much more global genomic surveillance. The first virus that was a real game changer, the Delta out of India, it was 200 days from the time that virus was first identified till we knew that was a big troublemaker. And I think we need to give our South African colleagues real kudos for having identified so quickly Omicron and also gotten the sciences to say what are the implications of this new virus. So I think we need ongoing surveillance. We really need a much more systematic global testing to monitor. And then the other thing is we have to have public health officials with a clear idea, how to respond, because you can't catch up. That we've seen over and over again, states or countries that say, well, let's see how it goes. No, I mean, you don't get a do-over. And once you let it get ahead. So it's a little bit like, in some ways, analogous to weather prediction. I mean, we have reduced weather-related deaths by 95% over the last 5 decades by being able to pick up the warnings. And, now when there's a hurricane coming, some people still say, well, I'll wait to see it on my horizon. But most people will, once there's an alert around that, will change their behavior appropriately. And that's what we need to do. We need to be ready to pull back. I mean, when you're in the middle of a hurricane, you're not going to say we're going to keep the schools in session. And when it gets really bad, you're going to evacuate. So I think having a stronger set of a more global and systematic, continue the improvements we've had in reporting, but then be really clear what are the tripwires. So we can make decisions and also think through on our some of our non-pharmaceutical responses, like closing borders. I mean, we sent, again, an awful message to South Africa for honesty. And it's despite these border closures, where it has gone global. So I think it's both the early warning, but also what do you do with the data? How do you respond? And be ready for waning immunity or new variants to really trip that wire.
Absolutely. Thank you very much. Professor 𝐏𝐞, coming over to you. I'm kind of combining some questions here, but we've had several questions about hospital systems over the longer term. If this virus does become endemic, like the flu is, which already obviously puts seasonal strain on hospitals, if the same happens with COVID-19, it becomes endemic and causes a multitude of hospitalizations yearly, just as the seasonal flu does. Do you expect that hospitals are going to have to increase system capacity because this is going to be an ongoing thing? Like, are we going to see kind of regular bumps right now with the capacity that we have where ICUs kind of get overwhelmed if we do see endemic COVID-19 that has these occasional outbreaks? Sorry, Professor Woods. I was moving on to Professor Woods with that question. I may have misspoken.
Okay.
Sorry, Professor.
Yeah.
I think this is a really important element of a change to whether endemicity or during surges, and it's really developing surge capacity, which has been stressed throughout the last couple of years. We're seeing that in many ways, both in access to diagnostic tests, and having just-in-time supplies for almost all of our medical devices, etc., including masks, to being reliant as a nation, or having each nation being reliant on a supply chain that has proved to be vulnerable. All those elements have come together to stress the system. So I think that the healthcare infrastructure needs to be resilient in that regard, and it needs to be equitably resilient, making sure that access is not denied to those least amongst us, or at least least resilient amongst us. With regard to our workforce, I think that's a very important part of this, and we've seen burnout at tremendous frequency. I'm sure we've all felt it to some degree. The ICU docs and nurses have been and first responders have been our true heroes in all of this. And the capacity for them to continue to respond to surges is going to no doubt be diminished. And so we need to replete that workforce, particularly during these surges, so that we can tolerate those. And that means we need to make sure that vaccine is required in our health care systems. We need to make sure that people adhere to masking at a minimum during these surges in the healthcare system. But I suspect, as I mentioned earlier, that this will become much more the norm in hospitals, at least, if not in all healthcare situations, even as we move past or into the endemic phase.
Absolutely, thank you. Oh, sorry, go ahead if you weren't done.
No, that's sufficient.
Absolutely, thank you. Professor Vasudevan, coming back to you, there's obviously all this discussion of moving into an endemic phase. I don't know if there's much research on this, but are you concerned with these vaccination campaigns? Obviously, it's a global pandemic. For those who were interested in getting vaccinated, there's this urgency, there's so much death. But if we move into an endemic phase where we are just accepting COVID as kind of part of our ongoing lives, are you concerned at all that it might make, if ongoing vaccinations are required, annual boosters, that there might be a less of a general sense of urgency once we're talking about it as endemic versus pandemic? And how in vaccination campaigns can you kind of overcome that and restore in people a sense of urgency that you still need to get this, even though it's just something we're living alongside?
Yeah, that is a great question, Greg. And I think that's something that we need to think about very seriously as we move forward. As you mentioned, there is a sense of urgency right now among people in terms of the pandemic, and just the fatigue from COVID, wanting this to be over, is motivating a lot of people to get vaccinated. At this time, 80% of our population that's 5 years and older has been vaccinated. And so that's a tremendous achievement for a vaccination campaign. I think let's first acknowledge that. But usually as we move towards more endemic infections, we start to see some complacency set in, right? The flu vaccination rates, for example, are much, much lower than the COVID vaccination rates that we are seeing right now. And the way in which we have overcome that is, again, to streamline the messaging and resources around vaccinations to occur with the timing of when a surge might happen or when we might see increased number of cases. And so that's something that we would have to do moving forward. And that's where early warning systems and these global surveillance systems would play a big role. Again, I think moving forward, we need to focus on messaging around the importance of vaccines. As I mentioned, our goals are twofold, right? They are to prevent deaths, preserve life, and to reduce the societal and economic impact of COVID-19. And all the data that we have right now continue to point to vaccines as our most powerful and effective tools to achieve those goals. So we have to continue messaging around the benefits of vaccinations in achieving those goals.
Absolutely. Thank you, Professor Vasudevan. Professor Quick, I'd like to come back to you. As Professor Vasudevan just mentioned, we've got good vaccination rates here in the US, but obviously there are countries where far fewer than 10% of the population have received a vaccine. And as you mentioned earlier, this does allow for the appearance of new variants, which quickly spread around the world. There doesn't appear to be a collective plan across the world to get us to an endemic phase. And how crucial is is a plan to increase vaccination rates in all countries? How essential is that going to be to get us to a global endemic phase in this thing?
Well, a couple of things on that. One is I think we need to really right now the array of vaccines that we have is not what we need to get us to an endemic phase. And the reason why I say that is we need the efficacy varies a lot among the different vaccines. The advantage of the vaccines that we have now is they were put in place quickly. The disadvantage is that the sort of effort you do to get long duration and stretch out the doses, and also to be able to attack many different parts of the virus so that you don't lose your immunity. So the first step is it needs to be to get together the world's vaccine, the regulatory authorities and the vaccine folks to really say, okay, what is the target profile for vaccines that we need on an ongoing basis? We're not going to be able to maintain vaccination protection globally, or even in for the highest risk populations worldwide, if we have to have a booster every 6 or even 12 months. We can manage it here, but managing large-scale vaccination programs requires, first of all, having the right vaccine. So that's a piece that the vaccine development up to now has been driven and very quickly and effectively by a competitive approach, but now we really need an approach to get the best possible vaccine. And then the next phase of getting the systems going, we're going someplace where no public health program has gone before, with a level of vaccination and that's needed. So we need to look at the supply chains. And one of the things that's helped us here in the US to try to overcome the level of vaccine hesitancy we have is to take a kind of all viable pathways approach. The traditional vaccine program runs through typically a public cold chain and all. But we countries may need to look at bringing in, the equivalents of the CVSs and other viable mechanisms. And that's where there isn't a clear plan for that. I think we are definitely moving toward, with the work of WHO and the Gavi Alliance and 𝐓𝐡𝐞 and others, 𝐓𝐡𝐞, the Coalition for Epidemic Preparedness that's been very active in vaccines. I think we are moving in the right direction, but we need to lay out all of the issues that need to be addressed and make sure that we are on vaccine development, on vaccine distribution systems, and on the actual administration system, really looking at this problem in a creative way, recognizing the magnitude of it. We have some good examples from countries that have been more effective and in achieving high level of vaccination.
Sure, thank you very much. Professor Woods, moving on to you again, we've had an interesting question here about, we've talked a lot about the movement to the endemic phase, what it would take, what it would look like. But what are the kind of benchmarks that we would need to look at to realize that we are in an endemic phase? Is it kind of hospitalizations being at a certain level or staying at a certain low level for a period of time? Is it case counts? Like, at what point would you expect the WHO and others to say, okay, yes, we are now in an endemic phase? Or is it just not that simple?
Yeah, I'm going to come. I did want to comment just briefly on Dr. Quick's point earlier, if I could, and it was alluded to by Lavanya as well, and that is the importance, I think, particularly as the disease becomes endemic, however we end up defining that from a global perspective, is to not build another siloed program. And I know Dr. Quick agrees with this, that one needs a healthy healthcare infrastructure globally. And this is the one more opportunity to push that agenda forward. And this is where the political will needs to be there, not only just for the surveillance systems that need to be there as the early warning, but as actual healthcare delivery. And all the opportunities that Dr. Quick mentioned, leveraging novel approaches can be used robustly across a number of different threats. So that's just one thing I would mention in follow-up. With regard to the metrics or the indices for defining an epidemic, it kind of depends on one's perspective. The epidemiologist uses the R0 level, and when the virus gets down to an R0 of 1 or less, the epidemic is either controlled or over, and you're in the endemic phase. I think that's probably an oversimplification. And again, I think there is this breathing that's going to take place where we see intermittent surges of both known strains or replacement strains, as we alluded to earlier. And so we're liable to see bumps in case counts in general. And again, identifying those case counts is going to be dependent on having those surveillance systems in place, making those granular enough so that we have sequencing capacity, so we can say what are the new strains that are there. Someone on the chat already alluded to the BA2 strain, where you have a subvariant of the current Omicron, and we just don't know enough about that subvariant, but we'll continue to see those as they emerge. Severity is going to be really important for us to monitor, and that's a rather simple way for us to monitor, because we should be able to see increase in hospitalizations and increase in deaths as markers of new strains that are more virulent, or a waning of immunity that may take place. So I think we are going to see that drop in cases. As I said, we're liable to. We've probably are seeing the plateauing of cases as it is, if not an early drop here, at least in the United States and in many other parts of the world with regard to Omicron. the ability to again identify the new emergence of those surges is as this one fully recedes, and we're not seeing large numbers of cases. People have different numeric metrics for that definition. But it really depends on where we are, or it depends on setting up that system for identifying those new surges. That's going to be really important.
Sure, absolutely. Thank you. We've still got lots of questions coming in. I appreciate it very much. We will get to as many of them as we can. So panelists, as I'm whizzing through here, if the answer to the question is short, that's fine. We're just going to try and get through as many as we can. Professor Vasudevan, I asked you a little while ago about, the transitioning to an endemic phase and getting the attention of individual people. But I'm wondering from a government and institutional perspective, obviously there's been an awful lot of money thrown at the vaccination campaigns over the last year because of this emergent situation. I'm assuming it's going to be extremely important for governments and others to maintain this kind of investment in vaccination through the endemic phase. Are you concerned? Because I know something Professor Quick has written about in between public health emergencies, funding drops off and surveillance drops off. How important is it going to be institutionally and for governments to kind of continue a full court press on this and continuing big investment in vaccinations? Are you concerned that that could drop off and also harm the vaccination rate moving forward?
Yes, absolutely. And it's something that we have seen before, this drop in funding and prioritization as pandemics and endemics evolve. And I think it's really important for us to maintain the progress that we have made in terms of vaccine development, in particular, because as Dr. Woods and Dr. Quick mentioned, we need better vaccines. I mean, we have really good ones right now, but we do need better vaccines. Combination vaccines are often helpful when thinking about rolling out vaccination campaigns. So if we have a flu plus COVID vaccine, that's something that could be particularly helpful when messaging and increasing demand. Things like pan-influenza vaccines, which are currently under development, I think we need to invest additional resources in developing those vaccines. And remember that we currently don't have good vaccine candidates for children under 5. So that's another area of research where we need investment and continued progress so that we can expand the eligibility in terms of who gets the vaccine. In previous years, we have relied a lot on vaccine mandates for childhood vaccines. We have not really done that with flu vaccines, but that's been our way to increase vaccination coverage. Now, as diseases become less common, people's perceived susceptibility to disease decreases, their risk perception decreases, and so there is similar issues with government investments and policy making, right? So there is less emphasis then on things like the COVID pandemic that could recur. So I think continued investment is important in terms of vaccine development. Another area where I think continued investment is needed is studying vaccine hesitancy, understanding especially the role that misinformation has played in our response to this pandemic, in particular, how it has hampered our ability to roll out vaccinations more quickly. I try to think of how many more lives we could have saved. So again, that's an area of research where additional investment is already happening and continues to be needed moving forward.
Sure, absolutely. Thank you. I'm going to whiz through a few more questions here before we wrap up. Professor Quick, we have a question here in the chat asking how concerning is the appearance of COVID-19 in a sizable portion of white-tailed deer in Ohio and Iowa? I'd certainly not heard about that, but I mean, given your experience in pandemics and epidemics, is that something that should be a red flag, a light bulb, an alarm bell right now?
It should be. It shouldn't be a panic bell. So the issue is we know that the SARS-CoV-2 virus does get into animals, and we had the earliest sort of scare last year with the mink in Denmark, and they culled 2 million. We've got in Singapore right now, Hong Kong. Hong Kong. They're picking up 2,000 hamsters where there's concern about spread. So it is a concern. What we need to do is the epidemiology, just finding the virus in an animal. We need to find out how transmissible it is. And this is part of the One Health, the human-animal environment connection element, which is really, really vital for this virus. And so the answer is, yeah, we need, when we find those sorts of populations, we need to figure out what that means and then act accordingly. We have we're monitoring for bird flu on a regular basis, and periodically when there's a really worrisome variant, then there is some culling. So that's, yeah, I mean, I wouldn't panic, but I definitely something that needs to be monitored and is being monitored as we go forward.
Sure, thank you. Professor Woods, another question here about what an endemic looks like for people who are high risk versus average risk. We know that, people who are immunocompromised have had to be extremely careful through this whole thing. Is this something where people in those kind of positions who are vulnerable for any reason are looking at the rest of their lives being hyper vigilant? Or do we have any sense of what an endemic phase of COVID-19 might look like for them?
Yeah, I really appreciate that question. Here at Duke University in the Medical Center, we have a very active transplant program, so that particular population is relevant. Of course, we've known about the outsized impact on our elderly population who have a senescent immune system for a long time. And the question about behavior going forward as we move into different phases of the evolution of the COVID disease is going to depend a lot on individual risk tolerance. Each of those individuals going to have slightly different immune limitations that we really don't understand that well. So the more scientific understanding we have of the most vulnerable amongst us, we can all do better in protecting them. But going back to what Dr. Vasudevan was highlighting before, if we maintain a high degree of vaccination, it does protect all of us, even the most immune compromised amongst us or vulnerable amongst us. And so I suspect we will have those individuals with a lower risk tolerance, and they will be more likely to mask, be more likely to be socially distant, will be more attentive to that those epidemiological cues that come out of our early warning systems, so they know when to tighten down their behavior. That all of us will likely do at some point or another.
Sure, thank you. And I'm going to stay with you, Professor Woods, for a moment, because you mentioned earlier about international travel, and we've had a question about testing to get into other countries, for example. Is that something you think is just going to be a part of international travel as through an endemic phase, or do you think that's something that countries might start to relax once we get used to living alongside an endemic version of SARS-CoV-2?
Yeah, it's a tough one, and I think Dr. Quick alluded to this earlier with regard to the difficulty in, usually we are, by the time we start limiting populations from coming in and we start punishing those for, countries for being good stewards of their surveillance programs, it becomes problematic. I think that routine testing is a reasonable thing. I think testing in general should be encouraged because it allows for early detection. Early detection allows for early intervention, and it tends to be that that testing is brought into situations too late or later than it should be, and access to testing can be difficult. And it also provides kind of a basic market for the testing companies, which is not a bad thing in the sense that it keeps testing available, so companies don't shelve product or stop making product like they did just prior to the Omicron variant. And so I think testing in many travel situations makes sense. I think it ultimately will make it safer, but the notion that you're going to impact the spread of epidemics that way, I think is where you have asymptomatic or pre-symptomatic shedding is highly unlikely, and enforcing bans is probably a step too far.
Sure, absolutely. Thank you. We're going to wrap this up here shortly, but I'm going to get one more question for each panelist. Professor Vasudevan, I'd like to move on to you. As we know from various headlines and from what our other panelists have said this morning, most, if not all, of the people in the ICUs across this country with COVID are unvaccinated. We know that there are some people that just, despite all the evidence in front of their faces, just don't seem to be willing to get vaccinated. And of course, that's caused a lot of anger amongst people who are vaccinated. Is there anything that we have learned? Because obviously these people are also going to be targeted for vaccination campaigns once this thing's endemic. Do we have to accept as a society that some people, there isn't an approach that's going to work for them, whether it's facts or whether it's concern for their loved ones? Are there some people that just can't be reached, or does the work go on to try and figure out, as you said, not the magic phase, but the particular approach that might work for those kind of people? What have we learned about that kind of vaccine obstinacy, almost, if that's the right word?
Yeah, definitely. I think, as I mentioned earlier, everybody has a different motivation for why they want to get vaccinated or not. And we've seen a big role for vaccine misinformation during this pandemic. The fact that, it's a new disease, there are new vaccines. So there have been a lot of complicating factors, I would say, in terms of our ability to message around the vaccines. So I think when we get to the populations that are very hesitant, right, typically our interventions reach those populations with very little success. And I think what we have seen to work in the past are those one-on-one conversations with health providers. Never say never, so people can change their minds, even if they are very obstinate in their decision at some point in time. But again, it's a process, so it needs to happen through those one-on-one conversations with health providers.
Thank you, Professor Vasudevan, and I especially appreciate your willingness to carry the torch of optimism forward through this thing. Professor Quick, I will come back to you. We've seen, there's this, it's now been labeled the vaxxed and done. People who are vaccinated have followed all public health guidance, continue to wear masks, and have just decided now that they've done all they can, and if people aren't going to get vaccinated, that's their problem, and are starting to do things more in a normal pre-pandemic way. If we want to reach an endemic phase, is it too soon for that? I mean, would you urge people that have been very careful and are maybe just sick of it that they just need to kind of stick with what they're doing? Do we risk something by relaxing, lowering our guard too soon?
Yep, absolutely. And I mean, we learned that 100 years ago with the 1918 flu. We had a fourfold difference in the death rate among cities around this country, and the thing was, those places that let their guard up too early, relaxed their protective measures too early, were the ones that were hit the hardest. And we as a public health community need to do a better job of making it clear that this is an evolving science, and the virus is evolving. I mean, 2 doses just don't do it. Again, of the mRNA viruses just don't provide the protection you need from Omicron. So I think it not keeping up with the latest public health advice will only prolong the pandemic for everyone. That's just a reality. But
sure,
that said, I mean, on the optimistic side, we have the tools. But I said it depends on what the virus does and what people do. And right now, not enough of us are doing what we need to do to get us to the end of this. I know it's tough. I've got grandkids, and I've got doctor, daughter and son-in-law, and it's tough. I know it's tough. But everything we've seen about this says we've got to stick with it till we get it down to a level on an ongoing basis that we need it.
Sure, absolutely. Thank you. And to close with you, Professor Woods, related to what Professor Quick was just saying, and I realize that the answer to this is probably thousandfold, but what do you think is the most important thing that either governments or individuals need to be doing right now to kind of get us out of an emergency phase and into some sort of phase where we can live with this thing and function as a society?
Yeah, there's no doubt that we want to get through this current surge, and I do think we'll be in a better situation from a population immunity standpoint at the end of that. The best way to do that is to follow the advice you've heard from Dr. Vasudevan and Dr. Quick, which is get vaccinated. If you haven't been vaccinated, get boosted if you've only had the initial series. Follow the advice of our public health community. Continue to mask. Tight-fitting masks are more effective for everyone. Avoid large crowds. We aren't ready to be doing that. The New Year's crowds and the holiday crowds, no doubt, added to this current boost. So following that advice. And moving forward. And I think we can do that in an optimistic way, just as was highlighted.
Sure, absolutely. Thank you. And I think we'll call it there. Thank you, everyone, for joining us. Thanks to our panelists, John O'Quick, Lavanya Vasudevan, and Chris Woods for sharing your expertise. I'm sorry we didn't get to all of the questions, although I'm sure the panelists are delighted we didn't get to the one about the NFL's overtime rules. Maybe next time. If you'd like to be notified about future upcoming briefings, please email 𝐓𝐡𝐞@duke.edu. In the meantime, please stay well, wear a mask, and get vaccinated or boosted. Have a great day, everyone. Thank you for joining us.